Thank you. I appreciate y'all coming out. The attendance for this grows every year. I'd like to thank Curtis Chastain and Brad Meek and his group for putting all this together. It's just impressive. Sure. It's impressive what they're able to do, and their hard work every year pays off in helping to educate our public as far as what their needs are and what we do as a medical professional. Each year they ask us to speak about different topics in men's health, and with urology, gosh, it just seems like everything we do is focused at men's health. So I never know which direction to go each year, but there just tends to be a lot of focus and a lot of worry and anxiety in the community about prostate cancer. That just seems to be a big topic on everybody's mind. So this year we felt like we would target this program about prostate cancer, but at the same time, I like to keep it very informal and answer really any question that you guys have. So my thoughts on things were that I would present, for 20 or 30 minutes sort of about prostate cancer, and then open the forum up for any questions that you guys have, and just keep it loose and make sure that that we each have a chance to talk and get something out of this. You guys benefit, and I benefit as well, hearing from you, and it's a learning experience on both sides. First and foremost, I guess, is, let me see how to make this thing work. What is the prostate gland? I get this question a lot from both men and young adults growing up. Is what is my prostate gland? Why do I have it? Why did God make this prostate? The prostate is basically a gland, just like a thyroid gland or any other glandular tissue in the body. It secretes a fluid, and the purpose for this fluid is a nourishment. It nourishes the male sperm that allows it to live and allows it to function and do the things that it needs to do. So it's a reproductive organ, very, I guess, similar to a uterus in the female counterpart. It has a lot of purpose early on in life. Later on in life, is it necessary? Our thoughts are, you can certainly live without it. There is life without a prostate, fortunately for us, just like there's life without a uterus. There are some changes that occur in a man's life without a prostate, but they tend to be minimal, and they tend to affect the quality of life. As we're learning more and more about the prostate and how to remove it and how to do things more efficiently, it tends to impact the quality of life less and less. Its location is, it sits at the base of the bladder. All right, and this is kind of, I guess that doesn't probably mean a whole lot to you unless you're standing up and you're thinking, I have the bladder. Everybody kind of knows where that is, right there above the bone in the front. Well, the bladder sort of funnels down, and then this glandular tissue surrounds it like a donut. And the urinary channel actually passes right through the center of this prostate, and then comes on down through the bottom of the penis and exits out the urinary meatus there. And so that's the location of it, which makes it a little bit tricky as far as getting to surgically. It's best accessed from a physical exam standpoint through the rectum, and that's why when you go to the doctor and they do an exam, you're actually feeling through the wall of the rectum to feel what the prostate feels like. And in general, an exam can tell you a lot about a prostate. It tells you about its size. It tells you whether or not there's any abnormal lumps or bumps, or maybe there's not lumps or bumps, but there's some firm areas in the prostate. Maybe the prostate feels soft and mushy, and maybe it's tender like an infection. And so those are all things that are important to the urologist or to the primary care physician taking care of your prostate. They all give us clues as to what's going on to make it where we can be more proactive and hopefully detect prostate cancer earlier on in its occurrence. What is prostate cancer? Well, the prostate cells are under genetic control. In other words, our body is sort of programmed for our cells to grow at a certain rate, and everybody's body's different, and we do tend to follow the traditions of our family. If our father's prostate sort of grew to be more enlarged than the average or usual male, then chances are we're going to fall in that category too. But what prostate cancer is that those cells lose the genetic control of their growth, and they begin to grow independently. And that independent growth is unregulated, and it progresses at different rates, but that out of control growth is what we call cancer. And unfortunately, as that progresses, it tends to end up impacting other organs and eventually ends up taking over our body. And so that's kind of what prostate cancer is. The other question I get, or a lot of questions I get, is, if I've got prostate cancer in my prostate, if I have cancer in my bone, is that bone cancer or is that prostate cancer? And that all depends really what those cells look like and where they came from. If a cancer starts in one organ and that same group of cells has spread through the bloodstream or spread through the lymphatic channels to another area of the body, it's still named by where it started. So if it starts in the prostate, spreads to the bone, and starts growing in the bone, it's still prostate cancer, but it's what we call metastatic prostate cancer. It has moved on. It's no longer just confined to the prostate gland. How prevalent is it? Well, prostate cancer it's the most common solid organ cancer. Okay, it's outnumbered by skin cancer. Skin cancer is probably the most common cancer that we see, but prostate cancer is a very close second, and it's estimated that about 1 in 6 men through their life will develop prostate cancer. This number is going to continue to grow, and maybe not necessarily because we're seeing more prostate cancer, but because our population is living longer. A lot of folks have suggested, and probably pretty accurately, that if a man lives long enough, he'll probably develop prostate cancer. The good news about prostate cancer is that for the most part, it's a fairly indolent, a very slow growing disease. Now there are different forms, and some prostate cancers are more aggressive than others. We'll get to that in a minute. But as a whole, prostate cancer tends to be a much slower growing cancer than your other cancers like lung cancer or pancreatic cancer, colon cancer. Those cancers tend to grow at a faster rate than prostate cancer. Still, it is one of the leading causes of death because of how common it is, and that's why we have such an interest in prostate cancer today. Fortunately, with the new advents in medicine, really since the early 80s, when we started developing a test in the bloodstream to look for prostate cancer called PSA, and because of seminars like this that have gone on for years after years, and the public exposure to prostate cancer has increased so much, prostate cancer now is diagnosed about 91% of the time as an early disease and clinically localized to the prostate. The significance of that is that clinically localized prostate cancer is very highly curable, okay? Whereas if it's not localized, then prostate cancer cannot be cured. It's not a disease that we have a chemotherapy for, that we have any further therapies that once this thing gets out of the prostate gland that we can cure it. That sounds scary, but what you have to remember is that prostate cancer is a very slow-growing disease. So the fact that we can't cure some prostate cancers doesn't mean that you're going to die of prostate cancer, because the real truth is that we can control this disease once it's spread so very well that most people die with prostate cancer rather than of prostate cancer. Okay? And if you're ever diagnosed with prostate cancer, you have to keep that, in the back of your head, is that most people, in fact, the large percentiles of people will die with prostate cancer rather than of prostate cancer, or be cured of prostate cancer. Okay? The 5-year survival rate's 99%. So it's not a disease that you hear very many people about getting, and all of a sudden 6 months later, they die. It's just not usually that rapid of a process. If there's been some neglect, if people aren't coming in, and you find this at a very, very late stage, then sure. I mean, you may have some people that pass away, on the sooner side with it, but it's because when they presented at a very, very late time in their life with prostate cancer. How do you get diagnosed with prostate cancer? Well, the typical patient that I see in my office is one that comes either worried and wanting an annual physical exam, getting checked, or B, was referred in by their primary care physician who found some abnormality. And those abnormalities are either A, they took a feel of the prostate and they felt a suspicious spot, or B, they drew some blood work and they saw that there was some abnormality to that blood work. Those are all important things in staging the prostate cancer. The first thing that you do in that situation when you have something that's suspicious is put you through a biopsy. A biopsy sounds kind of scary, but it's actually pretty easy. The way that works, you come into my office, you lay on a little table, and I have a little probe that's about like a finger. And I slide the little probe in. That probe will show me your prostate gland on a screen. Through that probe, I can use a little fine needle, just like I draw blood out of your arm, and I can put numbing medicine on the prostate gland, kind of like a dentist puts in your mouth. And that numbing medicine will make the biopsy a whole lot more tolerable than what it was, say, 3 or 4 years ago before we were really doing this numbing technique. Still a little uncomfortable. The pain threshold varies from patient to patient, but for the masses, I mean, it's a very well tolerated event. With that, we take a random sample, of course. Sometimes we target suspicious areas on the ultrasound. If we felt something, we target that. But nonetheless, we get tissue, and we look at this tissue under the microscope. And we get a report back from the pathologist that tells us either A, hey, there's nothing going on, no worries here, or B, yes, you have prostate cancer. Let me take you to, one of the key elements in once you've been diagnosed with prostate cancer is trying to find out how aggressive that cancer is. How likely is this to be something that's going to grow fast, or is this the usual prostate cancer? And there was a pathologist who dedicated his life really to an interest in prostate cancer named Gleason. And he came up with a huge recognition for us. He noticed that prostate cancer cells grew in 5 different patterns of growth by the way they look under the microscope. And he also noticed that if you took the most common pattern and you numbered that 1 to 5, you took the most common pattern in a biopsy sample, and you took the second most common pattern, that you could add those numbers together and it would come up with a score, a Gleason score. And that score would range from a 2 to a 10. And that was very highly predictive of how aggressive this particular cancer is. And so a 2 would be a very slow-growing cancer, and a 10 would be a very fast-growing cancer. And we use that data to help us influence how we're going to treat each individual prostate patient. Okay? So once you have that data, once you have the person's PSA, once you have how you detected that prostate cancer and what their Gleason score is, then you can make some educated advisements to the patient as to what stage they are and how they should be treated. The earliest stage of prostate cancer is T1 disease, okay? I mentioned this because if you ever get diagnosed with prostate cancer, this becomes important. You want to find out how far along your prostate cancer is at the time of diagnosis. T1 disease means that we picked this cancer up relatively incidentally. We didn't feel anything. There wasn't anything abnormal. We didn't have really any reason to look there for prostate cancer other than either A, your blood test was elevated, or B, maybe we were doing another procedure on you for benign prostate enlargement, okay? BPH or prostate enlargement that's not cancerous sometimes warrants treatment. We used to, we do a roto-rooter. We remove some prostate tissue. We look at this prostate tissue and incidentally we find some cancer. Well, that's T1 disease. Okay, that's the earliest stage that it comes. T2 disease means that we actually feel something. We feel a spot on one side or we feel a spot on both sides. And that's still organ confined. Okay, T1 and T2 disease is still organ confined prostate cancer. T3 disease means that the cancer that we have is now growing through the capsule of the prostate. The prostate is, you can picture an orange, and the pulp of the orange being sort of the prostate tissue itself, and then there's a rind around it. Okay, now unfortunately our prostate's rind aren't as thick as an orange, but more like a peach, with the peeling of a peach. And it has a capsule like that 9 times out of 10 contains the prostate cancer. But sometimes as prostate cancer spreads and advances, it grows through or into this peach rind and then maybe even locally into some of the surrounding tissues. Like I said earlier, the bladder sits nearby and it can invade into the bladder. And the other organ that it invades to is something called the seminal vesicles, which is a storage tank for sperm in men. If either of those are occurring, then that's T3 disease. T3 disease doesn't mean that you can't cure it, but it means that the disease is a little more advanced than just clinically localized, okay? T4 disease is, a little bit more different. T4 disease means that we've got some enlarged lymph nodes that cancer spread to. We've got some bone maybe that prostate cancer spread to. Maybe there's some spread into the lung, or maybe just locally into the bladder. But it means that the cancer has moved on from the prostate gland. And unfortunately, T4 disease is no longer a curable prostate cancer, but remember, it's a very highly controllable cancer, okay? So that leads us to what happens if we're diagnosed with prostate cancer? Where do we go from there? And truthfully, this is individualized down to each separate patient, okay? There is no one right treatment across the board for prostate cancer. There are options, and you have to look at each option and what fits best into the patient's demographics. How old is this patient? More importantly than how old, how healthy is this patient? What's their likelihood of living 5 years more, 10 more years, 15 or 20? These are difficult answers because no one has a crystal ball. As much as I know about prostate cancer, as much as I know about medicine, as much as Dr. Chastain knows, and any of the other gurus around the country, none of us know how many more days each of you have left. And so all we can do really is to take what we know statistically about a patient in their situation and try to project what their potential future longevity is. And we get fooled a lot. We get fooled into thinking that everybody's healthy, and then all of a sudden a year or two later something else shows up that, was, not predictable. We also get fooled into thinking somebody's a poor candidate, and then they end up, outliving everybody's thoughts. So you have to really look and see where a patient fits in and talk to them about what their desires are. The main treatments for prostate cancer for cure are radiation and surgery. Those are the two main things that cure prostate cancer. There's a third way of curing prostate cancer that's a little bit, I guess, less tried and tested, and that's cryotherapy, taking the prostate and freezing it. It's still considered a potential cure. It's a lot newer to the market than radiation and surgery, but it has its place. It's not done near as much as the other two, and there are some reasons behind that. But those are the three, I guess, main things to try to cure prostate cancer. To control prostate cancer, there's hormonal therapy, which is where we kind of manipulate some of the testosterone in the body that fertilizes prostate cancer. We try to take that away and really slow prostate cancer's growth down. It doesn't kill it off, but it slows it down considerably. And then there's the fifth option, which is doing nothing and just watching and waiting. And that seems like a terrible choice, but actually it becomes more of a choice in a lot of the patients that we diagnose. And that all comes back to what you think somebody's potential longevity is and what you think their aggressive nature of their cancer is. So you sort of have to really individualize each and every case to try to make the best decision. Radiation can be given in two different directions. One is externally, sending radiation beams into the prostate to try to kill off those prostate cancer cells, or internally depositing some radioactive seeds in the prostate. And there's pluses and minuses about each of those. But essentially they both result in good cancer control, good cancer cure rates. Surgery is a more aggressive form of treatment. Surgery actually removes the prostate, takes the cancer and everything out of the body. There are several different ways of doing surgery. One, you can come between the testicle and the anus to get in there, that spot. That's called a perineal prostatectomy, and probably about maybe 3 to 4% of surgeries done for the prostate are done that way. The other way of doing it is actually to come from above, called a retropubic prostatectomy. And that can be done in two fashions. One, with open surgery, which has been the conventional for years, and nowadays robotic surgery. And that's sort of some of the newer technology that's come into this disease. And I'd like to take y'all a little bit through the robotic fashion. We actually, Rich Meyer brought the robot for us to look at today, and it's up on the second floor there if y'all have an interest in going by and seeing it. Any way you treat prostate cancer, whether it be with radiation, or whether it be with surgery, or whether it be with hormones, the two main things that you run into is a diminishment in the quality of life of bladder control and erectile function. And unfortunately, there's no way to get around those possibilities. They do differ somewhat in their timing of their onset and their percentiles. But unfortunately, everybody that undergoes curative treatment for prostate cancer is going to face that risk, that it may impact their ability to control their bladder, it may impact their ability to maintain an erection. The fortunate thing is that most of those patients that do fall in that category can be fixed, depending on how far they want to go into fixing it. Some of the oral agents, Viagra, Cialis, Levitra, they solve that problem for a majority of the patients. There are other things that you don't hear quite as much about, but there's an injection that you can place in the penis to help with erections. There's a suppository that can be placed in the urethra. There's a vacuum device that we can use to get an erection. And in worst case scenario, just like women can get breast implants, there's actually an implant that we can put into the penis that's functional. It's mechanical, and that can solve an erection problem. Unfortunately, it doesn't make it grow. Can't make it bigger, but nonetheless, it helps it to function. Bladder control, a little bit more bothersome of an issue, but again, there's at least 2 surgical approaches that can be done to help a man regain control of his bladder. Just like women have a bladder lift, men can have a sort of a bladder lift, or there's actually an artificial muscle that can be placed around the urinary channel to help with bladder control. Moving on to the robot. The robot is sort of the newest, sort of latest and greatest approach that we have to removing a prostate gland. And there's some distinct advantages the robot has and offers over the conventional surgery. That biggest advantage is the length of incision that we make to get the prostate gland out. The typical prostatectomy that's done retropubically makes an incision slightly below the belly button and goes down to that bone there in front. And it ends up being a length of about maybe an inch on either side of your hand, okay? About that sort of width or length. A robot is done through several stab incisions. So stab incisions are more like a ballpoint pen that you place into the belly. So totally, if you added all the cuts up, maybe the lengths end up being about the same, but there's a difference in your healing and your perception of pain from a stab wound as opposed to a larger cut. So robotic surgery tends to help people get back on their feet quicker. It tends to have less hospital stay time, and it tends to have less post-operative pain. Okay. The other advantages that the robot has, or potentially has, is that there's a fair amount of magnification to the camera when we're looking at the prostate. And so for that, we feel like we can see the prostate better when we operate that way. We feel like we can get a better reconnection between the bladder and the urinary channel when we sew that back up. The interesting thing is that if you look at the data, long term, as of yet, there hasn't been a huge difference in bladder control after a robot versus open surgery, or erectile preservation after robot as opposed to open surgery. So that may be coming in the future as we learn more about the robot and as we learn more about the prostate and utilize this technique more. But as of right now, don't want you to get misled into thinking that your chances are less of having a diminishment in your quality of life based on robot. But there are, at the same time, there are a lot of advantages the robot offers. So if you get faced in the situation of having to choose a modality for your treatment, just remember those things and use that information in helping you make decisions. Yes. I'm sorry. I'm wandering, the wandering speaker, huh? I guess at this time I'd like to just open the floor up for questions that you guys may have, something that I didn't touch down on, or you'd like to expand on, or personal questions. The rectal exam, huh? Okay. So the question is PSA, and if you have a normal PSA, why do you need a prostate exam? And that's a very good question, and a lot of men feel like you don't need that. But if you look at the data, about About 85% of prostate cancers are picked up by PSA alone. Okay, so if you are just going on PSA, then you're going to miss 15% of prostate cancers. About 85% of prostate cancers are picked up by rectal exam alone without PSA. So there, once again, you're going to miss probably 15% of prostate cancers. But if you combine the two data, the PSA and the rectal exam, that picks up about 98% of prostate cancers. So in my opinion, you need the rectal exam to pick up the 15% or 14% that you'd otherwise miss. It is. And we talked about genetics of the prostate and how, you know, if it's in your genes that your prostate is going to grow big, if your daddy's prostate grew big, same is true for prostate cancer. It does run in families. Well, you know, it's not really a cancer that we get because of bad things that we do, like lung cancer. But prostate cancer does have some environmental factor to it. I think it's been shown a high-fat diet has been implicated in causing prostate cancer or contributing to prostate cancer. So if there is a high-fat diet, yeah, we think both in breast cancer and in prostate cancer, basically in hormonal cancers, a high-fat diet is sort of implicated in.
11 years ago, I had a
So that doesn't change your rate of prostate cancer or risk of prostate cancer. It may. No. So what he's telling us is that a few years back he had a procedure done to channel out the interior of the prostate gland to help him urinate better. And does that change his risk for developing prostate cancer? And the answer to that is no. It may change his detection rate of prostate cancer, because when we trim the prostate gland out, we obviously change some of the architecture of the prostate, and so the exam is a little different. And so you have to sort of take that into account when you're evaluating him on a rectal exam, that he's had a prior TUR, and some of the things that you may feel that may make you more worried about a nodule or an abnormal growth pattern, maybe because he's had some channeling work done on the inside. Sure. Trying to urinate from it, right? Sure. Yeah, and it doesn't, but that doesn't. None of that puts you at a higher risk for prostate cancer. So. Well, not necessarily. Just because you don't empty your bladder doesn't put you at a higher risk for bladder cancer either. Bladder cancer's more associated with people who smoke and environmental exposures to the benzenes, toluenes, and the dyes that we see out in our plants. Yeah, well, that has you with an increase for sure. But yeah, you should, if you continue to see your urologist or your primary care physician and get your analysis periodically, prostate exams, you should do fine.
At what point should you be concerned about the PSA numbers?
Okay.
A slow growth year over year, or a dramatic change?
Sure. So the question is PSA, and how does that relate to prostate cancer? Since every man has a prostate, or if you hadn't had it removed, every man has a prostate, you're going to have some level of PSA. PSA is a hormone that the prostate cells release into the bloodstream. And it's going to vary from one person to the other based on how many prostate cells they have in their body and what those prostate cells are actually doing. Some are more active in producing PSA than others. And where's the worry range? And that's a good question, because it varies somewhat. if we look at you know, large populations of men, we feel like that their PSA should range anywhere from almost 0 to up to 4. Now, what's more concerning than your absolute number of your PSA is your trend in your PSA, and that's what he's getting to. You know, let's say you go to the doctor and, you know, 2 years ago your PSA was 1, and then the next year it's, you know, 1.5, and the next year it's 2. Is this concerning? And the numbers that we use on that is that we don't want to see the PSA go up more than about 0.7 units in a given year. Okay, if it's growing, we know the prostate's going to grow throughout your life. Therefore, we're expecting your PSA to rise somewhat year by year. But we don't want to see an accelerated growth rate of more than about 0.7 units in a given year. Doesn't mean you have prostate cancer if that happens, but it means you probably ought to go for a biopsy and get checked out. You know, the American Cancer Society says that we ought to do a rectal exam and a prostate and a PSA on you about once a year. And that's the general recommended thing for an asymptomatic man. Now, if you're having prostate problems, then you probably should get checked more often than that. If you're having any PSA problems or anything that's more suspicious for prostate cancer, then you ought to be checked more often than that. Regardless of your age, yes. Yeah. Yes, sir.
Why would PSA
Yeah, that's a good question. I don't know that we have exact answers for that. We know that the prostate gland is a growing gland. That also means that there's cell death as well. And so our prostate undergoes atrophy. And sometimes we'll do a biopsy and we'll see atrophy. And what atrophy means is that you have just like a muscle that's not in use will shrink. You know, some of our prostate cells, as they grow, they'll outgrow their blood supply or what forth, and then they'll shrink and sort of die off. So, I know one answer, you know, may be that that your prostate cells are sort of in that process. Some are dying off, some are growing, and the PSA has some fluctuation. But you're right, I do see that sometimes. The other thing is that there's other things that stimulate the prostate gland to produce PSA other than cancer. Prostate infection is probably the most notable out of that. And at times of higher activity with the infection, you get more irritability in the prostate cells, and that may cause your PSA to be artificially higher. When that settles down, your PSA may drop back down to a more normal activity. If you're diagnosed with prostate cancer and your PSA has declined rather than increased, I would say you probably have pretty stable disease, and it wouldn't alarm me at all with that. I don't know that I wouldn't necessarily. I mean, if there's active treatment going on, you know, then that's a good sign. You know, if you're getting treated with hormones or you're getting treated with any of the chemotherapy agents or anything, then that's a good sign. But in the absence of treatment, if you're just on a watchful waiting program, then you know, I wouldn't necessarily get excited about a decline in your PSA, but at the same time, it would reassure me in that prostate cancer is not very likely growing at any kind of significant rate. Yes, so that's probably the most notable areas of spread of prostate cancer. It tends to spread to the hips, what we call the acetabulum or the hip joint, the pelvis, the bony pelvis, also to the back. The spine is a common site, and the ribs are a common site for prostate cancer to metastasize to. Once again, that's late in the stages of prostate cancer. There are. I mean, any man is you know, unfortunately susceptible to prostate cancer. It does tend to occur more often in black men than in white men. Nothing that we really know. No known reason why that should be the case. It's just something that we notice, and for that reason, we tend to advise black men to begin their prostate screening earlier in life, usually around age 40 to 45, whereas in white men it's usually around age 50, provided they don't have a family history of prostate cancer. And if you do have prostate cancer in your family, we usually advise about a 5-year earlier start on that.
What's the thing that you've had prostate removed and blood tests later show that your PSA number is fine again?
Okay, so what happens in the patient that had prostate cancer and he went through treatment for prostate cancer, be it surgery or radiation, and all of a sudden the PSA begins to climb again? Well, it means the prostate cancer very likely has come back. And the question then is, has it come back in the area of the prostate, or has it come back because of some spread of some cells to another organ somewhere else? And that we have to run through some tests to try to help decipher. The other thing that's sort of helpful in that is that if the PSA recurs quickly after surgery, after radiation, then that tends to mean that the prostate cancer cell was probably somewhere else rather than locally. And weirdly enough, if it comes back, say 5 or 10 years later, it tends to be more likely that it's coming back in the same area that the prostate used to sit. Why does that occur? That's a difficult question. I don't think science knows. Maybe it's that there's some prostate cancer cells that are sort of sitting in some of the nerve tissue that surrounds that area, or some of the lymphatic tissue that surrounds that area. And because prostate cancer is such a slow growing disease process, that you have a couple microscopic cells, and it takes some years to show back up and begin to produce enough PSA that our test can detect it.
Can you say more about hormone treatment?
Sure. Hormone treatment is a way to control or slow down the growth of prostate cancer. And essentially, prostate cancer cells feed on testosterone. Testosterone is a fertilizer for them. Testosterone makes them grow. Exogenous testosterone, or getting testosterone outside the body by shot or cream or some of the ads you see on TV, doesn't cause prostate cancer, but it will cause it to grow faster. Withdrawing that testosterone tends to put prostate cancers sort of in a state of remission, not in a state of cure, but sort of in a state of remission. The prostate cancer tends to die off. It doesn't grow as fast, and it may sit indolent for a while. Now, unfortunately, prostate cancer is smart enough that eventually it will learn how to grow independent of testosterone. So it's not a cure, but in most cases, if you can withdraw that growth stimulus, it takes the prostate cancer a long enough time to learn how to grow independent of testosterone that people end up passing away of older age or other medical issues. So that's sort of how it works. Now, it can be given, hormonal therapy can be given in three fashions. One, simply remove the testicles. You take the testicles off, you get rid of 90% of the testosterone, and that's over and done thing. There's also a shot that will stop the testicles' production of testosterone, and you can give that based on what dose you give. There's monthly shots, there's 3-month shots, there's 4-month shots, there's 6-month shots, and you can give those repetitively for control of prostate cancer. Kind of a newer fangled thing now is giving intermittent hormone therapy. And what intermittent hormone therapy is, we give you a shot, we watch your PSA come down to, maybe give you a series of shots, watch your PSA come down to a level that we're all comfortable with, and then we stop giving you the shot and we watch the PSA, and once the PSA kind of starts to go back up, then we hit you with another shot. And that can vary in each individual patient. Some people might get one shot and not have to have another one for 2 or 3 years. Some of them get a shot and 4 months later their PSA is back up and they got to get another one. So it varies, but that's intermittent hormone therapy. I'm not sure if I answered your question or not. If you had anything more specific.
Well, how about the effects of hot
Yeah. So the side effects of removing testosterone are very similar to what women go through when they have a hysterectomy and they remove their ovaries. You can have a diminished source of, sense of libido or sex desire. You can also have hot flashes, and those both can be combated with medications. But that is one of the potential side effects that you have with treating cancer, prostate cancer hormonally. Yes. Sure. Yeah.
Can prostate be responsible for erectile dysfunction, and why do some men at early age get it and some men at older age get it?
Sure.
Some men never get it at all.
So is a prostate gland essential for erections? And we've learned that the answer to be no, and the reason why I say that is because we can successfully remove prostate glands and people go on to have erections. But it's definitely tied to it, and the way it's tied to it is that there are nerves that run along the lateral side, or on the outside of the prostate gland, very, very close to this prostate gland, that go to the penis that are responsible for erections. And damage to those nerves definitely impairs one's ability to get the erection. There's also blood flow that goes to the penis for erections that kind of doesn't come through the prostate, but it comes down close into that area. Originally, we used to think when we were doing prostate surgery that we were just damaging the blood flow. We didn't really know much about the nerves. But Pat Walsh, a very well-respected urologist from Johns Hopkins, sort of pioneered some of the research on the nerve-sparing prostatectomy, and essentially most every prostatectomy is done now with nerve-sparing in mind. And we're actually able to save those nerves. Now, they still can get bruised and damaged through that process, but in probably at least half of patients, we're able to preserve potency. Why does erectile dysfunction occur? It can be a number of different things. It can be related to testosterone. It can be related to psychological factors. It can be related to prostate infections that irritate that nerve. It can be related to diseased blood vessels. It's the same kind of diseases that occur that cause heart blockage. Diabetes, smoking, small vessel disease. Those blood vessels are about the same size that go to your heart, and the reason why there's such a hype about ED is because we want to try to pick up on those guys who are having ED as an early sign of finding heart disease. And you hear about these 45-year-old guys who just suddenly keel over from a heart attack, and you'd like to think, well, gosh, is there something about that patient? I mean, was he having maybe some erectile problems beforehand that could have keyed us into to some other disease processes that are going on? We're all susceptible. There are a host of different reasons why a man has erectile dysfunction, and it can occur in early 20s all the way through late in life. And just because you're living doesn't mean you're going to get ED. And there are plenty of folks who are lucky enough to live in their 80s, 90s and still have fairly normal erections. So it isn't something that you have to live with. It's something that we can definitely treat and make better.
What is your opinion of the wide or the value or effect of the wide array of nutritional supplements?
Where does nutritional supplements play a role in my treatment of prostate glands or prostate cancer?
Is there a benefit to medications to try and improve the health of the prostate?
That's a good question. I think there's some marginal data out there that suggests that. Unfortunately, there's not a lot of great data to say that you need to do this or do that. There's a lot of money being made in that area. You can evidence that by the numerous TV commercials that are out there for prostate supplementation. Where I sit as a physician on that is that I don't know of any supplements out there that are harmful to us. Whether they actually impact a man's risk for prostate cancer or whether they actually impact a man's risk for prostate infection and so forth. I don't push anybody in that direction. I tend to say, you know, it's there, maybe it works, maybe it doesn't work. I know it doesn't cause any harm. If you're having problems, then I'd say go ahead and get on it and give it a try and see if it reduces that likelihood of you getting infections. If you have a high risk for prostate cancer, your daddy, you know, maybe an older brother, an uncle, you know, all had prostate cancer, and yeah, I probably would try to do everything I could to avoid getting it, and I'd try some supplementation. But for the masses to just all of a sudden go out and take, you know, a huge amount of supplements, I don't know that. I know there'd be a lot of money spent on that. I don't know how much of that would actually impact your likelihood of getting prostate cancer. I don't know if that helps you or not. Some of the symptoms of bladder cancer. You know, bladder cancer it is a lot like prostate cancer early on. It's fairly silent. You may not pick up on it at all. Some of the things I tell you may be something that you feel already. You know, some increased urinary frequency. You have to go to the bathroom a little more often, maybe a little more urgently. You can't hold it quite as well. Blood is the #1 kicker for bladder cancer. You know, if you ever see blood in your urine, it's never normal. Never normal. It didn't occur because you lifted something. It didn't occur because you ate beets. It didn't occur because you know, you exercised the day before, and the fact that it goes away in one day doesn't mean a thing. You need to have your bladder looked at. You know, if you ever come down with a single episode of blood in your urine, then your urologist needs to check you out. I just see too many people that come to see me because they had blood in their urine, and you ask them, well, you know, this ever occurred before? Well, it occurred once, you know, 6 months ago or a year ago, and you look in there and they've got, you know, aggressive invasive bladder cancer, and that totally could have probably been prevented had they paid attention to themselves 6 months ago and been in your office. Yes?
What's your opinion on conventional radiation treatment versus proton radiation?
Yeah, good question. Probably better answered by one of the radiation oncologists. I think that they're both very effective. I think that proton therapy is a marketed strategy. If it were significantly better, I would think that we would all move to doing proton therapy. Our goal as a physician is to offer what's the best that we have out there available to you. It doesn't matter to us how you get treated. We want what's best for you. Anytime you've got somebody out there that's having to market their self as being a better or being, you know, this or that, then I always raise an eyebrow as to why. You know, why are you, if your therapy is so much better, then why are you having to get out and market it? It should just take off, and we all should start doing it. So I think proton therapy works. I think proton therapy is probably as effective as external beam therapy, but I don't know that it's any better than conventional IMRT. Side effect wise, maybe it's less, but realistically, that's a little outside the realm of what I offer, what I do. So probably the better person to answer that question is the radiation oncologist. Sure. What's my views on cranberry juice? If it tastes good and you like it, drink it. I think it has shown some marginal help with bladder symptoms, reduction of bladder infections. I think that if you're having to hold your nose to swallow it and so forth, then it probably doesn't offer as much benefit as you need to reduce that part of the quality of your life. So, but if you like it and tastes good, I would drink it and enjoy it, and maybe it, you know, might keep some bladder infections away. Cranberry tablets and so forth, you know, kind of same thing. I'd try them for a couple months and see if you think that they are offering you some distinct advantage. If they are, stay with them. If not, then I don't think that they're mandatory. Yeah. Me too. It's good. There you go. Yes. Yeah, so the question is, do I feel like that we'll eventually get down to being able to do localized surgery? You know, if you come in with a kidney cancer, I can actually go in and just trim that cancer out of the kidney and save a good bit of that kidney behind for a large number of people. Will we be able to do that with prostate cancer? And the answer is unfortunately no. Prostate cancer is a disease of multifocality. What multifocality means is that if you look at someone's prostate, if you take a prostate gland out, which we do with surgery, and you look at it, probably at least 5 out of 10 times, we're going to find more than just one isolated cancer. We'll find the one we knew about that we hit with the biopsy, but we're going to also find other spots in the prostate gland, small cancers spread through. So unfortunately, unless we have some visible way of seeing cancer cells in the future that we can go in and target each individual prostate cancers, we won't be able to go in and just remove the cancerous section of the prostate unless there eventually is some way of being able to visually look and find each prostate cancer cell. Sure. Sure, good question. What causes prostate infections? That's a good question because nobody really knows the answer. We know what makes a man more susceptible to getting it. You know, infrequent sex is probably the #1 cause. You have a man who is used to ejaculating a certain number of times a week, a month, what forth, and then all of a sudden that changes somewhat. You get stasis of that fluid in the prostate gland, and we feel like that probably sets up infection. So that puts men who travel away from their wives at greater risk. Traveling salesman, Army folks that are away from home, prisoners that are in prison, or wives that are having problems and or marital issues. Those are all things that tend to exacerbate prostate infection. Caffeine tends to be a chemical irritant to the prostate. Not all prostate infections are necessarily bacteria, and caffeine tends to be a chemical that irritates the prostate. Along with that, alcohol, spicy foods, tobacco tend to be chemical irritants to it. Trauma to the prostate, riding a tractor, cutting the grass as a lawnmower, that continuous bouncing, riding in a truck on the prostate tends to make you a little more susceptible to getting infections. But why they occur and how you prevent them is something I wish we could come up with, because it would definitely help us all out. What's that? Okay, does recurrent prostate infections lead to prostate cancer? And the answer to that is no. Just because you're a person that comes in with lots of prostate problems doesn't put you at any higher risk of developing prostate cancer than someone who's never had a prostate infection. Enlarged prostate glands actually probably lower your risk for prostate cancer. For whatever reason, men that come in with great big enlarged prostate glands have a lot lower likelihood of getting prostate cancer than those with normal size or small glands. Thank y'all.